Hi, I'm Dr. Alexandra Drakaki, an assistant professor of medicine and urology, the medical director of the GU Oncology program at UCLA and the Institute of Urologic Oncology. So the question is if patients with metastatic or recurrent bladder cancer are at an increased incidence of brain metastases, and if so, what is the imaging modality we should use? So as you know, bladder cancer is the 9th most common cancer worldwide. 90% of bladder cancer are transitional or urothelial cell cancers, while the rest are small cell cancers, adenocarcinomas, squamous cancer, or mixed histologies. Most common presentation is hematuria or pain, depending on the metastatic site, and brain metastasis from metastatic bladder cancer is very rare, especially for urothelial cancers, while the percentage might increase in small cell histologies. Given the rarity of CNS disease, typically the guidelines do not recommend upfront imaging of the brain unless clinically indicated. Having said that, there are some clinical trials in which baseline brain imaging is required. What is very important to mention is that as the systemic therapies for bladder cancer have significantly improved with the recent FDA approvals of 5 immunotherapy drugs since 2017, followed by erdafitinib, the FGFR inhibitor, in April of 2020, and enfortumab vedotin in December of 2020, the life expectancy of our patients has significantly prolonged. So as someone can imagine, since patients live long enough with metastatic cancer, that increased survival increased the risk of developing eventually brain metastases. Therefore, at this point, it's not unreasonable to consider changing our guidelines and add brain scan, at least at baseline and periodically thereafter, but probably annually for patients with certain histologies like the small cell bladder cancer. Now, what is important to point out is what is the preferred imaging modality. Many patients would like to have CT scans, as a CT scan is much faster, but many have poor kidney function due to age or comorbidities, and so contrast is not safe to be offered. Therefore, the gold standard brain scan is brain MRI with gadolinium that can also capture metastases that could be in the posterior part of the brain. The benefit of early detection is obviously early intervention with either stereotactic radiation or resection, and less frequently whole brain radiation unless there are multiple lesions. What is very interesting and important to point out is that while chemotherapy drugs do not have penetration of the blood-brain barrier that well, the hope is when using immunotherapy is that those activated lymphocytes are crossing the blood-brain barrier and actually act as the drug. In bladder cancer, we do not have many studies as patients then be excluded from those trials. So our practice is based on our experience treating individuals and seeing the responses. However, there is significant literature supporting the benefit of immunotherapy drugs, such as nivolumab and ipilimumab, in treating CNS disease in patients with metastatic melanoma or clear cell kidney cancer. So extrapolating from these malignancies, it's reasonable to think that similar efficacy will apply for patients with brain metastases being treated with immunotherapy agents. And as always in medicine, we ask ourselves and our patients, are we going to change our practice and our treatment plan if we perform a new test? In this case, definitely we're going to change our plan if we find that one of our patients has brain metastases and will be approached differently. And therefore, it's worth considering that initial assessment.